So let's get started. Ladies and gentlemen, you are most welcome to our session this late afternoon. And of course, because it is towards the end of the day, a very special thank you for coming to discuss in the next 90 minutes, or slightly less now. The title of, or the area of focus for us this afternoon is Impact of Global Health Work. And we shall use AFREhealth as a case to discuss impact. The key thing here is impact of global health work. And I'm your facilitator this afternoon, or coordinator, Nelson Sawankambo from Makerere University. And very recently, I became the vice president of AFREhealth. And of course, my boss is here, the president of AFREhealth, who you may have heard in another session speaking. Now, what was the motivation of having this session? Focusing on the impact of global health work. The theme of this year's CUGH 2024, if you see at the bottom there, is Global Health Without Borders, Acting for Impact. I'm not sure how many of you stopped in your tracks after reading it and reflected on it. Acting for impact. So that was one of the motivations of having this session. But also, some of us have been thinking for the last maybe 2 years or thereabout within AFREhealth. That is a grand challenge. And what is that grand challenge? It is about impact. So I ended up, and colleagues, asking ourselves, if indeed the theme of this year is acting for impact, what does that mean, acting for impact? So when you reflect, step back and reflect, each of us uses the concept impact, and I've heard it many times since this conference started. People are saying impact, impact, impact. And each one may be meaning a different thing. So we each define impact differently. Some focus on the academic results, the papers published, that's impact. Or we published in a high impact factor journal, that's impact. We each talk about it differently. But is there a better way of defining impact so that we all use a common language? Is it necessary anyway that we all mean the same when we use the word impact? For example, impact may mean, since our purpose in the business of health is to give people better lives, living longer, could it be impact would focus around living longer or better lives because of our work? And we don't simply call impact or relate impact to those academic outputs that I've mentioned about. And what is the pathway to impact? When you look at the work that you do, what is the pathway to impact? Can you explain it? Of course, it may not be easy because there are so many different inputs that may contribute to living longer, for example, or having a better life. You may have examples from your own work on what you call impact, and it would be nice if later on this afternoon, you could share some of those. What is going to happen is that the presenters here will each speak for about 8 minutes, and at the end, there's time for you to ask questions, make comments, so that we leave this room at the end of this session with having reflected on impact and maybe carrying forward your suggestions. Since we are going to use the example of AFREhealth, I thought that I would start off by saying little things about AFREhealth, but others will say more about that. This is a huge interprofessional experiment on the African continent. It's a huge experiment. Why is it a huge experiment? Because AFREhealth embodies and allows any universities or any institution that is involved in the business of training health professionals to be a member. So if you can imagine how many institutions are out there. And the focus is on interprofessional work through education, research, and services to the people on the continent. In the center of that map of Africa, you see that I said, we haven't discussed it with my colleagues in AFREhealth, but I think they would agree that the impact should be health transitions, so that the people transition to better health and longer lives. So, impact, as I said, we've been hearing the word since we got here. Impact, here I tried to show that I think impact, people are seeing it in all sizes, in all shapes, and hence those shapes in the circle, each one meaning impact. Some may be positive, and that's where people usually look. They usually don't talk about negative impacts or unexpected, and yet those other two also exist. So let's remember some key issues as we use AFREhealth as a focus to help us discuss. That AFREhealth has to show value on the continent. What is the value of AFREhealth? And what is its impact on the continent? We are building AFREhealth as we sail, not a very good or easy way to do business. And AFREhealth should become a learning organization. It should move from risk to resilient. Risk to resilient. That it is a resilient organization. But impact of whom? Whose impact are we talking about? There are so many stakeholders for impact. The publics, various publics, civil society, the trainees, the trainers, the funders who support it, and also government and policymakers. With those few remarks, I want to go to our distinguished speakers for them to share some ideas that will take us on this journey to discuss impact. The first speaker is no other than Eric Goosby, and this morning I'm sure you are all in the plenary session, and he was beautifully introduced. Actually, as I sat there, I wondered, what could I do in the next several years or few years so that at some podium they would introduce me as him. Eric, you are welcome. We want to listen to you in the next 8 minutes to hear what you say. The reason Eric is our first speaker is because, as you heard this morning, He did a lot in PEPFAR, and AFREhealth, the roots are born in PEPFAR. Please.
Well, what a wonderful introduction by a person that I just hold in such high esteem for so long. I thank you for that, and I can only say that it is on the shoulders of individuals such as yourself that the rest of us started and stood on them to push our agenda further down the road. But you were doing it long before I certainly was, in an effective and impactful way. But I want to, Professor, really underline it's about impact. And I think that what has been part of all of our lives has been watching science happen where a finding results in a change to a guideline, a diagnostic therapeutic intervention that needs to be disseminated, and that needs to reach the populations that suffer from the illnesses, but that chain of engagements is fragile or non-existent for so many populations that suffer from the illness. It is the reason that we, as academic medical centers, must prioritize and continue to describe disparities in outcomes as the main reflection of our work. We are not satisfied with taking the science, giving the science to policymakers to make a policy, and having that policy come back and inform program is a orchestration that requires so many hands and brains that it frequently has the ball dropped. What AFREhealth, I hope, continues to expand is a higher level of understanding of the importance of that training element being the basis of the health interface with the population, and that training and the individuals that are trained continue to have an assessment of the quality of their work over time, not just one point in time. And I think that is fostered with a clinical layer of in-house faculty that are part of the training faculty for interns, residents, fellows, and postdocs as they move through the hierarchy of their training in whatever system they're in. But I think that our ability to have a system, a infrastructure that can deploy and surround individuals who are challenged with these needs to develop delivery systems for populations that are not already up and running, that there be a resource that individuals can turn to that have the ability to recognize disparities, understand the outcomes that are related to the interventions that you've stood up and put in program, and the kind of intellectual honesty to hold yourself accountable at one point in time and over time. I think the acknowledgement that nursing level providers play a disproportionate role in delivering guideline changes for HIV, TB, malaria in all the settings that we've worked in, and that part of the expansion of service capability must focus on that nurse provider as well, not just the physicians, but also the nurses. So I'll stop there.
Thank you very much for all those brilliant comments. I think they set the stage very well for our discussion. Let's go to the president of AFREhealth. By the way, for those who don't know AFREhealth, it is African Forum for Research, Education, and Health. Els Chiguli is the president.
Good afternoon. I think this is what is called standing on the shoulders of giants. Speaking after Professor Nelson Sewankambo and Professor Eric Cusby. They are my heroes in global health. I feel really humbled. So I was asked to say something about AFREhealth experiences, its major achievements, and challenges to sustainability, and our long-term view of impact. It's not moving. Where? No? Okay, it's moved, thanks. Yeah, so I'll begin with the end. So how are we thinking about impact? And some few months ago at the Global Health Week, we had a satellite on impact, and I attended it, and I really loved what Joe Collars described as impact, and I thought for us at AFREhealth, it really reflects how we are thinking about this. So there's it's not showing really well, but it's okay. There's the first order, which is the scientific results or policies that lead us to the second order. So we do scientific research, and hopefully it affects the policies, and these policies will affect people. Then from there, that evidence that we produce is the second order, and this helps really implement things that improve the lives of our people. And to go to the third order, then we have people living longer and having better lives. And that's how we are thinking about impact at AFREhealth. And I think that's what Professor Sewankambo described. So at AFREhealth, we have a vision and mission, and that one you can read from you can read about it from our website. But we've tried to align our vision to that of the African Union Commission of 2022, which we think is really relevant for Africa. Having an integrated, prosperous, and peaceful Africa driven by its own citizens, representing a dynamic force in the international era. And we would like to fit in there and see what we can do towards achieving this. So how do we function at AFREhealth? We have several activities. I'll just take you through a few of them. We have our annual symposium every year, which takes place in a different country every year so that we can reach our stakeholders. Then we do research. We've done multi-country research. We do capacity building. We conduct webinars that were really great for us during the COVID-19 because this was new for all of us. So all of us learned through those webinars, and we continue with these webinars for capacity building. And we have technical working groups. These are communities of practice because we are an interprofessional body, so everybody needs a niche where they can fit. So we have these technical working groups, and it depends on what your area of interest is, and you can join one of them. Then we have interprofessional student exchange with South to South, run by Faith Nawaji. I hope she's here. And then we really value partnerships. We have South to South collaboration is one of our strengths, and then North to South collaboration. So we have many key partners, PEPFAR, NIH, ASA Africa, CDC, UCSF, IDI, and many others. So we really value partnerships. So just to tell you a little bit more about our annual symposium, we hold it, as I said, every year in a different place. And last year we had it in Mozambique, where we had 189 participants from 25 countries. The most popular one was in Nigeria in 2018, where we had 365 participants from 29 countries. And this year it's going to be in Nairobi, and we have some flyers around so we are inviting you to our annual symposium this year. It will be 6th to 8th August, and it's going to be really interesting. So please, we would love to have you there. So we've run some major projects which we are really proud of. We have one which is called Strengthening Interprofessional Education to Improve HIV Care Across Africa, STRIPE HIV. This is an interprofessional course of about 23 modules, including one of COVID, which we developed after COVID came in. And we've trained over 16,000 health professionals on how to manage HIV. And this is sponsored by PEPFAR through HASA, and we have worked with UCSF on this. We have what is called the Program for Research on COVID-19 Effectiveness, PROVE in short. It's running in 13 countries, supported by IDI, National Institutes of Public Health, with AFREhealth, and it is sponsored by MasterCard Foundation through Africa CDC. We are very proud of our IPE student exchange program. It started off, we had planned for it to be a south-to-south collaboration, but face-to-face. But then after COVID, we ran it virtual, and so far we've had 180 students that have participated from 13 institutions in 10 countries, and also sponsored by PEPFAR through NIH with ECFMG FEMA. We have the Professor James Hakim Leadership Development Program. This is very important for us for mid-career academics to gain leadership skills. And we've trained over 61 in 13 countries. And our multi-country research that we do is also very impressive, and we've had many publications that have come out of it. But we have some challenges as an organization. We're a young organization. We started in 2016. We are still building our capacity, especially in managing funds, and this takes time. And we have a good, small secretariat led by our executive director, Georgina Yeboah. I hope she's here. I'm sure she's here somewhere. And it's really effective and is gaining capacity over time. We are depending mainly on grants and projects, and you know, these have a duration, maybe 5 years, 3 to 5 years, and this affects long-term planning, so it's also a challenge. We've had one large NIH grant with funding from PEPFAR, which has been supporting our secretariat and many of our activities, and it's about to come to an end. So, and as you know, when you depend on funding, donors and funders can also be unpredictable, so that is also a big challenge. And then there's the issue of impact assessment. It requires time and expertise. How do we really show that we've impacted the lives of the people in the region that we serve? And that's why we've opened it out for us to discuss and see what you really think we could do to maybe measure it, or how we can really make sure that we impact the lives of our people. We have a large membership. We have over 1,000 individual members, and most of these, this is a good thing. It's an opportunity, but it is also a challenge in the way that concerning fees, most of these are from low and middle income countries, and so they pay very minimal fees, but at the same time they have great needs, and they expect AFREhealth to meet their needs in terms of capacity building and improving their careers. And so we really need a lot of expertise and funds for us to meet their expectations. And of course, there's transition in leadership that happens in every organization. Is both a challenge and an opportunity. But we can see that we have really expanded our reach within the region. The only countries that are in blue are the ones where we have not, we don't have members as yet, but those who have been following, you can see that we've really expanded our reach within the region. So there's this African proverb that many hands make light work. So by getting together as AFREhealth, having all these stakeholders at the table and having you people to support us, we hope that our work will be lighter and that we'll be able to impact the lives of our people. Thank you very much.
Thank you very much, Elsie. I'm sure you all felt like you are hearing it from a president of the organization. Now, one of the things she said is that of all our annual meetings, symposia, one which was very exciting was in Nigeria. And since it was Nigeria, it makes sense to invite a Nigerian to come and speak to us. So the next speaker is Dr. Priska Adejumo. She is an honorable treasurer for AFREhealth, but more importantly for the discussion today, she leads the evaluation of AFREhealth. To find out, in the last 5 years or 6, what has NIH investments achieved? We received a grant from NIH, which is ending in about a year's time. And so we used it to start off AFREhealth, and she's leading in that evaluation. Priska, you are welcome to talk to us about evaluation for impact.
Thank you very much. It's wonderful to speak after superhero and hero has just finished, and the next person is the president of AFREhealth. I like to say I'm a nurse, which is an important part of my introduction. I don't want to miss that out. So my assignment, thank you very much. My assignment is very simple. Is having heard what AFREhealth is all about and understanding the perspective from where we are coming. I want to present to us a brief proposal of how AFREhealth is approaching an impact analysis. And I believe someone is going to be helping me. Oh, thank you, it works perfectly. I don't want to enter into a ditch, but thank God it's fine. So why is impact important to AFREhealth? As we all know, as individuals, if you fail to assess yourself, then you have actually planned to fail. So as an organization, we really want to determine whether the goals of AFREhealth were met. We are interested in looking out for the sustainability of this organization in terms of knowledge generation, knowledge sharing, collaboration, and so on and so forth. It is important for us to be able to measure the satisfaction that the recipients of various activities and services that AFREhealth renders, to what extent are they satisfied with this? And hopefully, at the end of this journey, we hope we'll be able to make recommendations that will provide further sustainability and strategic planning for the future of the organization. AFREhealth Impact Analysis is titled A 5-Year Analysis and Proposed Research Agenda, LAFIA 5-YAPRA as an acronym. It means conducting an analysis of the entirety of AFREhealth between 2018 and the just concluded year 2023. And the overall objective of this, like I have explained earlier on, is to find out to what extent AFREhealth has been able to achieve its aims among vital critical stakeholders. We're interested in looking at all the activities that Elsie presented to us, and we want to find out how effective have these been in addressing those problems that are uniquely African problems and to which African solutions have been provided. The project countries, if you observe, I have some countries in red, I have some in black. Those that are in black are the countries that have signed on, have subscribed to participate in this project. And those that are in red are countries that we are looking forward to have people tonight or this evening here in this audience are subscribed to. We really need individuals from those countries that are in red. For example, in West Africa, we have Nigeria, we have Ghana, but we do not have people from Niger Republic, Sierra Leone, Senegal, Togo, Cote d'Ivoire, Burkina Faso, Mali, and the Gambia, for an example. And the unique selling points of AFREhealth is the fact that it is interprofessional in outlook. This is important, and this is what uniquely differentiates AFREhealth from so many organizations. Therefore, we want to make sure that in terms of geographical spread, the entire regions of Africa are covered. In terms of linguistics, we don't want to leave anyone behind. So as much as possible, if you are here tonight from any of these countries that are in red, please do not leave the hall without enlisting to be part of this project. The methodology is very simple. We employed a mixed methods approach where we have some forms of qualitative tools as well as quantitative parts. The qualitative part, we intend to carry out some forms of focus group discussions, key informant interviews, as well as in-depth interviews in all of these countries that we've mentioned. While the quantitative parts we've already developed a survey tool that is going to be launched on AFREhealth website in the next 1 week from today. We had announcements on the AFREhealth website, and individuals volunteered. We have over 50 people, and based on what we needed, we selected 22 of them, who are the ones actually driving this agenda. We've had the tools translated from English to French, to Arabic, and to Portuguese. And the study participants we're looking at members as well as non-members who have participated and have engaged in at least one of the various services and activities that Elsie presented to us between 2018 and 2023. And maybe, okay, I should mention a few of them. Annual symposia that have been, organized so far. The small grant awards, we have investigators across Africa who have been sponsored and funded, rather, to conduct wonderful studies and projects in their various countries, capacity building programs, governance structure, technical working groups, and so on and so forth. As Elsie presented earlier on, we'll hope to be interacting with all of these people to find out how and to what extent has AFREhealth achieved these goals. We hope to analyze the data, systematically organizing all the information that we are gathering, and break them down from various qualitative approaches that we're employing, and integrate them into one continuous report, and be able to derive actionable points from there. In summary, the various activities that have been carried out up to date include the conceptualization of this idea, which actually started in Durban. And the Governing Council approved what was designed. And then the PIs of the NIH grant were given the assignment and responsibility to carry out this. And the call for volunteer, like I said, was shared across the African region. We have 50 people, out of whom 22 were selected. And we have had about 12 weeks of planning meeting, and critical review of the protocol has been conducted, as well as revision of the tools, both quantitative and the qualitative tool. Tasks have been assigned, and these volunteers have been grouped into qualitative and quantitative groups. The qualitative groups are the people responsible for data collection and data analysis on the quantitative part, and the qualitative as well. And IRB processes have been initiated. We've had IRB completed in 3 countries, Nigeria, DR Congo, and Zambia. And we are looking forward to completing that in Egypt, Rwanda, and Mozambique. And the tools have been developed and pilot tested. Various platforms, including WhatsApp and email, have been established to facilitate efficient communication among the volunteers. Our next steps, which is going to be my last slide for discussion, is that we're hoping to ensure completion of IRB processes in all key locations between March and April, and be able to deploy the survey tools for data collection and launch it on the AFREhealth website. So be on the lookout on the AFREhealth website. And then the third step is to collect quantitative and qualitative data, and then, of course, analyze them to assess impact. And finally, be able to write a comprehensive report and then disseminate the findings with vital stakeholders. Hopefully, we'll see all of you in Nairobi, and then you'll be hearing from us. Thank you very much.
Thank you very much, Priska, and thank you for reminding us that you are a nurse, because we didn't want to get out of this room or be in this room and then nurses say, you exclude us as nurses. We are always marginalized, but you've heard it from a nurse herself. Our next speaker is Dr. Haney, and you excuse me if I mispronounce your name, Yutnen. She is head of unit. This is WHO's unit on emergencies. She has done a lot of work in workforce development, including work in Africa, on Ebola, for example. So there's no way you can discuss impact on the African continent as far as health and people are concerned without talking about workforce development. So, Dr. Haney, please come and share your few thoughts regarding this issue on the continent.
Thanks so much, Professor Nelson and distinguished panel. It's really a pleasure to be here and have had a great chance to also join the other AFREhealth sessions today and yesterday, and really impressed of the work that you are doing, and looking forward for the impact assessment results from your work and all the rest that's going on. I'll talk a few words about the emergencies learning from the past few years, actually from the 7 past years that we've been doing through online learning, in particular for the Africa context, together with the African countries, our country offices of the World Health Organization, and what we found out there. We do also workforce capacity building programs, but for these 7 minutes, I think this is as much as I can handle in this session. And I think the online learning, when the first massive open online courses went live in 2013 in the format that we know them now, there was an immense promise and expectation that this online learning will magically change the whole education and somehow democratize it and somehow bring quality, bring access, bring everything. And I think many of those promises are still yet to deliver. But I think at the same time, all of us have, if not before, but latest with the pandemic, we've all become such online learners, probably those who've studied recently like myself. We've very accustomed to take our knowledge component from the self-paced online courses, then go to some more skills building learning in a more hybrid modalities, and then probably later do more peer-to-peer intense training in a more demanding setting. But the work that we've been doing in the past years, following actually the Ebola West Africa outbreak, when we didn't have means of servicing large amount of learners, responders in a rapid fashion through online learning, we decided to get ourselves prepared for next major events. And we launched our learning platform, the World Health Organization's massive open online platform, in 2017. And I've been married with this platform ever since. I've been working daily on the platform, and we really thought of the next pandemic, that what kind of a platform dissemination, what kind of a modalities we would like to have if and when, or for the World Health Organization, it's always a question of, the pandemic is a question of when, not if. And the next pandemic is the question of when, not if. And here we really wanted to have a highly accessible, rapid production, but also dissemination of learning resources. And we did a lot of work with Ebola outbreaks in the Democratic Republic of Congo and many other countries, with several other diseases like Zika virus disease in many of the Portuguese-speaking countries in Africa, in producing content for different infectious diseases together with the experts from the countries, adjusted and adapted them for the different locales and contexts, and then disseminated them through this platform. And this same modality has been working also for the COVID-19, when we went rapidly overnight in the spring of 2020, we launched the first COVID-19. COVID-19 didn't even have a name that time. The WHO's baptizing committee met much later in the spring, in March 2020. But we did this first novel coronavirus course already in the mid-January 2020, when there were only very first signs of the SARS-CoV-2 virus confirming and circulating. But this platform is really adjusted for low bandwidth and adaptation. So any content can be taken and adapted and used in next settings. And it's worked quite beautifully. Last year we received quite prestigious Learning Platform of the Year award from the Learning Performance Institute, and I think it's really thanks to the fact that we've been able to work with so many different infectious disease professionals, and also health emergencies. Also beyond the infectious diseases, we are also supporting learning response in Ukraine. We have 31 courses currently for the response, for the work in health response in Ukraine, mainly being used by military medics and others through mobile formats in Ukrainian. So the platform is highly scalable and works for really that first level of knowledge component. WHO's technical evidence science turn into short courses. We have currently 270 different course topics. 50 of them are on COVID-19, 35 other infectious disease courses. In total, we have 72 languages, including the 20 most spoken languages of the world. The 20th is the Nigerian Pidgin, and we have resources in Nigerian Pidgin, in Hausa, Kanuri, Lingala, Swahili, many languages. And the more there is demand for localization and adaptation, the more we work with countries and outbreak response and health emergency response settings to produce that learning. In WHO's health, in our world, we have this emergency response framework that tells us that within 72 hours of any health emergency event, we have to produce the first learning resources, and we do it week by week. There is Lassa, fever, like for instance in Nigeria now, I think we are responding to 5 different major infectious diseases at this given time. So the platform currently has 8.5 million learners, a majority of them health workers, a big bulk of students, all other professions as well, and half of our learners complete their courses. So the average course is 2 to 3 hours. They're very short, they are modular, but half of the learners complete the courses. So it's really at the high demand. And every day, like this morning, 3,000 new people have registered to the platform. So it seems to work for the kind of that first knowledge adherence and need. These are the learning diseases for different learning resources for different diseases, and the orange ones are the ones that WHO suspects would likely be the next pandemic. So the orange ones are the ones that our priority diseases for pandemic potential. Of course, the influenza viruses are also there. There are so many influenza viruses that have pandemic potential. We haven't covered them all in colors here, but these are the most high-threat pathogens for which we also have then the learning resources adapted. And what we are doing currently, learning from the last pandemic learning response, we are already now contextualizing, for instance, should the next pandemic be the Nipah virus disease. We are already adjusting the resources for locales where the Nipah virus is endemic, and for the languages and contexts that we know to anticipate. And we hope to be even better prepared as a learning response to the next major health events. And these Mpox, other diseases, there are many neglected tropical diseases that you see from the list, are circulating at all times. WHO's African Regional Office has produced a number of courses. This is a selection of some of the courses that we have on the platform. All of these are open source, accessible to anybody. And for instance, our end users, or our learners in different infectious diseases, they take the content and adapt it for their own use. And we have really nice body of evidence accumulating thanks to the Stanford Health Education Center, from where Dr. Jamie Johnson is here from. And we've been reaching out to our learners asking, how have you used our learning and what have you done with it? And we have really amazing use case from there, and I'll just show it in a minute. Dr. Nelson really asked to talk about the impact. So impact of this platform, I think in the past few years, we've really, in the beginning of the platform, we had mainly male learners, older male learners. Now we have a lot of younger female learners, and this was really the change during the pandemic. And when we've asked from our learners, what is it that you need? Especially the women learners say, I can't have anything time-bound because I can't bound myself on time. So the more it's self-paced, the more it works for me. And we really cherish of the fact that we've reached even more female learners. We know that 70% of the health workforce is female. So we hope that this platform also works even more so for the women. 3 out of 4 enrollments to the platform are from low and lower middle income countries, which is, this is the audience we really want to cater for. It's open source, anybody can come, but the disease courses, the health emergency courses, the Horn of Africa type of resources, they are all catered for instance, African use case. The adaptation is very high. We really have a lot of young learners, 20 years old and younger. We also have very many senior citizens. Actually, during the pandemic, before the pandemic, we didn't have anybody in the platform who identified themselves as older than 70. But during the pandemic, this vulnerable populations, the COVID-19, actually joined the platform, and about 5% of the learners are older than 70 years of age. And the highest per capita use take of our platform is in the islands. So the more remote island, in the island of Guam, 7% of the population is on the platform. So it's and it's the same for European, like the islands of Europe, like Malta and Ireland, they are the highest users of the platform. So it's really nice to see that it works in the remote locations. Our work is, WHO's work is mostly focusing on the priority 1 and 2 countries, the countries most requesting WHO support. Yes, I'll just finish here. And we've actually seen that more than 1 million of our learners come from our priority countries for the most investments that WHO does in the countries. And this is really important for us to see that actually the users in emergencies such as in Ukraine and many other countries, joined the platform. And it's been really a great journey. I'll just leave this here, the examples of how our disease causes have been used, in particular in Africa, and happy to take questions about this. Thanks so much.
Thank you very much for that presentation. We are doing great for time, and we want you to ask questions, to make suggestions, raise comments after these panel members or panelists have spoken. There's one person to go. And because we are doing well for time, let me introduce him more fully than the first ones, because at the beginning I was worried that if I give the long bios of these people, that we'll not have enough time for discussion. So the last one, and perhaps the youngest on this panel, is Joshua Greenback. He's a physician economist. He is NIH Fogarty postdoctoral fellow with the University of Michigan. His work brings linkage to medical and social sciences to develop new ways of thinking to address challenges in health. I said new ways to thinking. And that is important because we want you to develop new ways of thinking about impact. His research focuses on health, human rights, and social development, with emphasis on political economy and governance in health. He's a two-time Fulbright awardee and is a recent recipient of the CUGH Virtue Leadership Award for emerging leaders in global health. Sir, you are welcome to give your remarks. He has been living in Uganda for the last 10 years, and we're about to give him citizenship.
Thank you very much, Professor Sewankambo. I certainly was not expecting such a long introduction like that, but I'm truly honored, and I'm honored to be able to speak here today. I was asked to give an example of, quote, impact science through a specific project. And what I would like to do is start with the end in mind, the impact that is desired, and then walk you back to where the project currently stands today. The context of all of this work is the Ankole region of Uganda, including rural, peri-urban, and urban communities in the southwest of the country where I've been working for the last 15 years. But before I go into the details of the work, I want to start with a basic observation. And that's that the interventions needed to save millions of lives each year have existed for decades. This is the fundamental problem of global health. For example, roughly 5.2 million children continue to die annually from causes like pneumonia, diarrhea, intrapartum-related complications, all of which can be prevented or treated with cost-effective solutions. And this fundamental problem of global health gives rise to a fundamental question, which is why do governments fail to deliver available health interventions despite their affordability? We live in a world in which literally thousands of external actors intervene in dozens of countries around the world to solve these government failures. But rarely do we probe more deeply the fundamental causes of these failures, and even less commonly do we address them head on. So, of course, there are many factors that contribute to these governmental failures and the associated healthcare delivery gaps. The one that my partners and I in Uganda wanted to focus on is the widespread accountability gaps that hamper public health facilities in countries around the world. Of course, these public health facilities are the first line of care for most members of the population, but many of these facilities just don't function optimally. For example, health workers may not show up to work. There may be stockouts of medications and supplies, sometimes due to outright theft. Patients may be required to pay bribes for the provision of services. Patients may receive disrespectful or incomplete care. My partners and I felt that if we could address the core functionality of these health facilities, we had the potential to create a profound impact on health. So what's our approach been? Well, I run a health and human rights organization, Progressive Health Partnership in Uganda, and in talking with community members, partners at the Office of the Prime Minister, led by Commissioner Timothy Lubanga, colleagues at Makerere University, particularly Fred Muhumuza in the School of Economics, we wondered if we could develop programs that applied democratic governing principles to the health sector. We started to consider the political determinants of health, and we went back to the basics of the social systems that underlie all of our societies across the world, where you have a system that consists of people who elect politicians, who in turn select a set of public service providers, healthcare professionals in this case, and the services offered by those providers come full circle back to the people. Now, I'm, as Professor Sewankambo mentioned, I'm an economist in addition to a physician, and from an economic standpoint, there are many inefficiencies that can arise in this system. And so we asked whether we could address some of these bottlenecks. For instance, citizens may not be able to meet frequently enough with their democratically elected leaders, and as a result may have trouble holding them accountable for the quality of care. So we asked, can we design programs that, number one, improve the oversight that politicians provide of over the health sector? So that's at the second link in the chain. I don't think there's a pointer on here. And then number two, can we better enable citizens to hold their leaders accountable for the quality of health service delivery? That's at the first link in the chain. And of course, let me just mention, as I said, this is the basic model of any society throughout the world, which is to say that these are not merely Ugandan problems. These are human problems. Across the world, in the US included, we're seeing a crisis of accountable, representative, responsive government, and we need strategies more than ever to reinvigorate grassroots participation and accountability. So what have we done in this regard? Well, we developed two programs. The first is a community accountability meetings program, through which we run quarterly meetings between citizens and local political leaders on the topic of health service delivery. The meetings provide citizens a platform to exercise their health and political rights, to express both their compliments and concerns, and to hold their leaders more accountable for the quality of services that they receive. The second intervention is a health leadership program for those same local political leaders. This program consists of a series of workshops that we run for these leaders where we equip them with skills to more effectively engage with the health sector. For example, how do you conduct a monitoring visit of a health facility? And then, based on your monitoring findings, how do you use existing governmental channels, existing systems to create change within your own community in the quality of care? So what have we seen so far on the ground? Well, first of all, we've established proof of concept. We have successfully demonstrated the feasibility of both of these interventions and an associated set of data collection tools in a catchment population of roughly 500,000 people. We, in the process of doing that, have developed a number of implementation outputs, standard operating procedures, reporting tools, survey instruments, et cetera. This is just a small sampling of some of the tools that we've developed. What have we seen on the ground? So for the Health Leadership Program, we've achieved a minimum 80% participation rate throughout our workshops. This exceeded our expectations. And the training program provided a really rich platform that demonstrated tangible knowledge acquisition by these local leaders, and also offered an opportunity for cross-community exchange between different leaders and their experiences in the health sector. The Community Accountability Meetings program has shown a similar level of success and engagement of citizens and political leaders alike. So as you can see in the picture here, the meetings have led to very vibrant participation by citizens, with people passionately voicing their views regarding the quality of healthcare delivery. And just to give you a snapshot of some numbers from those meetings, I won't walk through all of this, but the bottom line is that the numbers at the top, the meetings have attracted, on average, more than 100 participants per event, and the vast majority of those participants have come from the general populace, including marginalized populations. And so that was a key goal of ours in the implementation, was to ensure that we were fostering representative, diverse participation of the citizenry. Where do we go from here? Well, with this proof of concept evidence in hand, we're now hoping to scale this up into a fully statistically powered randomized controlled trial where we'll pursue a number of research questions. Our main goal will be to quantitatively demonstrate the impact of the programs on health outcomes. And with that evidence in hand, we expect to be able to influence policy of the Ugandan government, as well as strategies of other civil society organizations. I mentioned that the Office of the Prime Minister has been a partner on this. They're our main government partner. And then more recently, we have received engagement from the Parliamentary Health Committee. Member of Parliament Margaret Ayebare, who serves on the committee and took interest in our work. And so, and since then, she has joined the project leadership team that we have for this work in Uganda. And which is to say that with these partnerships in hand, we're confident that at the end of the day, we can translate this work into real policy impact that improves people's lives. So I just want to bring this to a close by coming back to this idea of people-centered institutions. What's unique about this work is that we don't look to external aid programs to solve these problems. We're not injecting new resources into the system. Instead, we look to the knowledge, power, and agency of people themselves. We do this by operationalizing health and political rights. It's one matter for these rights to exist on paper. But how do we turn human rights into action? This work is about enabling citizens to come together, to exercise their power of self-determination, to take the lead in governing their communities, and to create a better future. And I think by taking such an approach, and by directly strengthening the governing institutions in the health sector, we truly believe that we can change the core functionality of these health facilities with a significant impact on health. And on that note, let me add one final point, which is to make the observation that matters of governance, of course, are not limited to health. Health is our starting point, but it's not our ending point. From health to education, to poverty, to climate change, to conflict, from the local to the national to the international level, all of the greatest problems facing humanity boil down to governance. They boil down to how we work together to manage our societies. This is the challenge for humanity. This is the challenge for our time. And with that, I just want to say thank you to all of the folks who have made this work possible, including our funders, and thank you again for the opportunity to be on this panel.
Thank you very much, Joshua, for that very clear presentation. Now, I would call upon you, the audience, to line up behind the mics. As I said, asking questions, making comments, and so on. Yes, let's get started right away.
Thank you. Thank you very much for the interesting panel. This question is for the AFREhealth team here. Have you considered a social return on investment approach to your impact assessment? And if not, the reason I bring it up, it's very well aligned with what you have outlined in terms of its mixed methods, it's stakeholder-centric, but it takes that one step further to calculate the social return on investment. And that metric can be very helpful in engaging private sector organizations and other investors and donors in the long run. And we're piloting this work with AMREF in South Sudan, looking at the SROI of their investments in human resources for health, and also in Kenya with peace building, and have had some interesting results and would love to understand if it's something you've considered or if it's something we may collaborate on. Thank you.
Can I steal the thunder out of your question by saying that now that this has been presented, we'll take up what you are suggesting. And we don't know where to find you. We will set up a collaboration with you, but we will follow up with you.
Thank you.
Yes, next person.
Thank you. I'm Damalina Kanjako from Makerere University. First of all, the chair was my teacher, so I'm happy to ask him a question. Yes. So you talked about impact, and my question was to add to how are you measuring the sustainability of the impact? Because it is one thing to have impact, but how is it sustainable? How can we make it a culture of impact? My second question is to the AFREhealth team. Have you considered being a vehicle for the member institutions to measure their impact? Because these are member institutions, and for sustainability, we need the strong institutions. You could be a vehicle to measure the impact of the institutions. Thank you.
Thank you for the question. That one I will leave to my two colleagues in AFREhealth, Elsie and Priska. Do you want to have a go at it now?
Members. Yeah, thank you very much. Part of what we intend doing is actually to get institutions.
The microphone.
It's hooked. To get the various institutions and get members from these various institutions actually conduct, for example, on the qualitative part, on the ground, that is the grassroots levels, try to find out the impact of AFREhealth on these various institutions. So definitely that is part of what we have in mind in doing. But I'm glad to connect with you after this meeting to find out more. The aspect of sustainability is something that one of the aims, like I said in that presentation, is that we're hoping that when Nelson was talking about impact, he mentioned three important points. He said negative, positive, and the consequences. So we're hoping that both negative outcomes that are going to emanate from this are going to point to some directions that AFREhealth should go even beyond this evaluation. So making it sustainable becomes very relevant in the next maybe 10 years, down the lane in the next 20 years and beyond. So I want to say, yeah, making it not just assessment in terms of evaluating it as of now, but moving forward beyond it. How sustainable is that going to be? We are also interested in that. And of course, the outcomes. Very good, we're hoping. If you have positive outcomes, how do you want to make sure you continue in that direction? How do you want to follow suit in such parts that have produced positive deliverables? And if they are negative as well, negative outcomes are also important. They are pointers to what have you been doing that you should not go there anymore? What are those steps that need a change? And what are the people saying on at the grassroots level? So definitely, in terms of impact, in terms of sustainability, these are areas that we hope to look to in this assessment. I think there's one more question that Elsie will attend to. Thank you.
I don't know which one you've missed, but for sustainability, we are hoping that we'll use this to reach to our funders and show them whatever has come out. If it's positive, so much the better, but there will be some negatives, as she says as well. And we can use this for our funders, for our members, to show them what we are doing, other than right now we said this is so successful, but whose perspective? It's the perspective probably of the president, and it may be biased, but if we can get it from the stakeholders, I think that will make a difference. And for social return on investment, we are really glad you've brought that up, and we are going to reach out to you. Thank you.
Thank you very much. Sustainability. We cannot disappoint Eric Goosby, who was there at the beginning, that AFREhealth is not sustainable. Roger Glass is right in the middle there. He was there also when AFREhealth was starting, and he was the director of Fogate Center. His immediate successor, Peter Kilmax, is also here from NIH Fogate Center. We are going to work tirelessly to make sure that this thing is sustainable, using even our internal resources on the continent through our governments. And we know that there are a couple of some people on the continent who have deep pockets. We shall approach them. Yes, please.
Hello, my name's Tara Casebolt. I'm from Loyola University, Chicago. I just wanted to make a comment/question about the online materials that you were talking about, the AFREhealth ones and also Open WHO. Those are great. They really expand reach for people, but people with disabilities are systemically left out of those kinds of programs, especially those with visual and hearing impairments and with intellectual disabilities. And I just wanted to make sure that they're being evaluated to determine their maximum accessibility for people from those populations using WCAG guidelines or various other universal design for learning attributes, just to make sure they can reach as many people as possible.
I think that is for Haney. But please, more people behind the mic. Yes, please.
Yeah, please go.
Go ahead. Thanks so much. So for some of the emergencies learning materials that we've produced in less than 3 days, we might not have taken all the aspects in the more than the hyperlegible font that we are using as a standard. But for many of the COVID-19 resources, we have them in sign language and in multiple different formats. So there is a try to take all the disabilities into consideration, but I don't think we are crossing all the markers yet, so there's yet quite some work to be done. But the best effort is there, and we've now also, following the pandemic, we've gone more deeper into what could be done in a kind of a stagnant online self-paced learning material format, that it services not only the hearing impairment type of audiences, but many others as well. So thanks for this very critical point.
Okay, let's take another question.
Thank you, Stefan Wisbauer from Lecturia. I have a question for Heini as well, and interested in talking to you afterwards as well. But specifically, I think if you have an emergency situation, it's very helpful to get feedback on the data of the people that you're trying to train to respond to this, right? So just curious if you, A, have a systematic approach too, or if not, if you have examples for you where you embed the content into locally controlled systems so they get data generative for the local intervention and so on. So curious to hear your thoughts on that.
Yeah, so we've done this with many countries. Thankfully, we have, World Health Organization has country offices in 138 countries, and We have particular strong use cases in countries like Nepal and Vietnam, where the ministries of health or public health institutes have actually taken our learning resources, fully adapted them, and disseminated in the local channels. Similar use cases in Brazil, where we have about 1 million learners on our original content that was fully adapted for Brazilian open education platform for public health professionals. So we have quite some, I think the multi-channel existence and presence is very important, and the localization, that we can only do so much. We have global guidance that only works for almost nobody, but it's only through the localization that it works, and this is probably what we're going to do, and I hope this is what we're going to do for the next major health events and the next pandemic, to provide the original source content, to have anybody who wants to take the material and repurpose and adjust it for themselves. And we've surveyed our learners in immunization, for instance, in the COVID-19 vaccine rollout. So, for instance, the cold chain is different in every country. So the vaccine rollout was dependent on having the appropriate right materials for all kind of a context. And I think the cold chain chapter was the most modified chapter of all the solidarity vaccine rollout resources that were also used by millions of learners. So this is a critical point, but we should do more, and in particular for the next pandemic, we have to be even more agile and able to provide that really original source content. But let's catch up more. So technology frontiers.
Okay, so Roger Glass.
Yeah, Nelson, you've challenged me to come up and take a reflection on this panel, and I'm delighted to do so. I remember well at the first MEPI meeting, there was a gentleman, an old gentleman, who had been the president of the African Medical Association, which was a group of a dozen or so medical schools that began in the colonial period. And they had not met for years. And MEPI brought together 13 schools on the continent with an aim of bringing you together. AFREhealth has, I don't know how many members now, but it's really brought many of the medical schools and nursing schools and schools of pharmacy and dental into a union in a network that communicates on a regular basis with everyone. It's an amazing accomplishment. And the challenge really is, how does the network empower this activity? I was struck in MEPI when you began that the sea cable was just going down East Africa. And we sat with Tedros at the first meeting, and he was bemoaning the fact that he had to go to India to buy 33,000 textbooks for the students because they had increased the number of physicians. And we sat with him and we suggested lightly that maybe he should get tablet PCs for the group. A crazy idea he never thought about, and we had never probably used ourselves. Milyar Derbu came back the next year having purchased 2,000 tablets, complete with all the textbooks, internet access, and hotspots on campus. And it totally changed. And by the end of MEPI, all of the students had tablets and were connected to the internet. It was a sea change in medical education overnight. After AFREhealth began, we just went through COVID, where we've gone from education in the classroom to education online, something that wouldn't have been possible at the beginning of MEPI, but it's possible now. And AFREhealth has had an education program to try to upgrade medical education throughout the continent. So I think that the value in the evaluation of AFREhealth should really be about how a network combining interprofessional education, the interactions and the co-training of physicians, nurses, paramedics together can really improve the quality of care. So I think it's a great experiment, as you said, to see what can be done. I just thought I would end with a quote from Bill Fege, who used to say that he asked the question of everyone, what's the biggest ethical problem in medicine? And some people would say abortion or end of life or whatever. He said the biggest ethical problem in medicine and healthcare is how governments invest their money. And without money, none of this good service can happen. And part of our aspiration with AFREhealth is that by making the economic and governance cases that you have, you can actually increase funding for healthcare of the entire population and be innovators in using mobile technologies, outreach, combined curriculum online that could be shared, things which are cost effective but could be really impactful. And I hope that as AFREhealth views its future, that these innovations in interprofessional education, into use of internet skills in training, in outreach with mobile technology and smartphones, and really in AI, you can be a huge change element. So I think that you've done a great deal to bring these schools together and the interprofessionals. The challenge going forward is how to best incorporate innovation to actually be able to have healthcare reach all people in sub-Saharan Africa, and to let us learn along the way how you do that so we might practice that at home. Thank you. This was a terrific session, and I'm so proud to see doctors and nurses and other professionals, women and men from around the continent, all together on this. And I can't not thank Eric Gooseby, whose vision to get MEPI going was really the seed for MEPI, HEPI, NEPI, and then AFREhealth, and that you've survived COVID, which many institutions did not survive, to come back with such a wonderful panel and a togetherness on this inspiration. So thank you so much.
Thank you. I don't want to disappoint the two people standing behind the mic. I'll give them half a minute each.
I'll be sure.
And then I'll ask Eric Gooseby to give us some reflections on what he has heard, and then we shall close the session. Please go ahead.
Sure. Thank you very much. My name is Luther. I'm an occupational therapist. I'm from South Africa, and I work at the University of KwaZulu-Natal. Thanks to all the speakers. My question is for Josh. Thank you for that lovely program. So what I wanted to find out from you is, since you have a lot of stakeholders involved, how did you get started, and how did you get a buy-in from all of them, especially the government or the politicians? Yeah, if you can just comment on that.
Just hold it there. Let's take the second one.
That's okay. I'll come up afterwards.
Okay. George.
Yes, thank you for the question. Of course, I think as your question alludes to, this is a very complex environment in which we work, where there are stakeholders with tons of different motivations and interests. What's always been important for me, whether in this project or really all of my work, is you have to be working with the right people. And so some of this work came together a little bit through happenstance, a little bit through planning, where there was sort of a convergence of interests and goals, and what we were doing as an organization on the ground in the communities where we work around governance and accountability. And then we learned that the Office of the Prime Minister had a program called the Baraza Program. And the Baraza Program in Uganda is a grassroots accountability program. And, you know, as much as people may say negative things about government and think that everyone in government is rotten, you know, there are actually many really great people working in government. And many great people working in the Ugandan government. And the Department of Monitoring, Evaluation and Inspection at the Office of the Prime Minister is just one example of that, and just some extraordinary public servants. And so we ended up crossing paths, and it was clear that we were pursuing similar goals, and developed these strategies that I discussed as a way to build upon the Office of the Prime Minister's accomplishments in the Barraza program. Has it been easy? Is there a lot of difficult terrain to navigate? Absolutely, but that's sort of how it started, how it started at a high level. And then I think just to wrap up, at the grassroots level, for the local political leaders, how do we foster their engagement? Well, interestingly enough, these leaders often feel neglected from many health and development programs. They feel like they're always left out, precisely because of the conception that people tend to have about politicians, right? I mean, many of our programs, we just want to come in and we want to work with the technocrats, and we never want to deal with the political leaders. These local political leaders on the ground occupy a really unique role, and actually by law have the mandate to oversee the performance of local government services, and so there's a real basis for the work that we're doing. And many of them were quite grateful that we were finally paying attention to them. Is that to say that you don't get bad apples in the bunch, and some who want you to, to essentially bribe them in order to collaborate together? Yes, of course those cases arise. But by and large, we've seen really remarkable cooperation, and I think those have been the reasons.
And it would be so great if all our member countries in AFREhealth, such work, could be going on, mobilizing different people in the communities, so that they work in partnership to improve the health of population. I'll give Dr. Eric Gosby here to give his reflections on what has gone on this afternoon, and then we'll close the meeting. Please.
Thank you. Thank you, Prof. Appreciate all of my colleagues at the table. Your thoughtful comments really have stimulated, I think, a positive feeling that it's gratifying to see that there is activity focused on trying to develop conduits of accountability that go and emanate from outcomes that are based in population numbers and the ability to identify, enter, retain, initiate drugs, start drugs, move individuals through the course of their illness to an undetectable level with HIV, with TB, to identify and treat with the appropriate medications so as not to develop a multi-drug resistant problem that persists, and how we buy in or get the buy-in of the political leadership, Josh, who you're absolutely right. They are the ones who are charged with the responsibility of taking care of the population. It's not multinational NGOs. It's not an NGO that comes in to do work with a population, as much as we appreciate and need that. But it is the governments that are charged with the outcomes. And it's now connecting the dots with the outcomes that are generated to be given and owned by the politicians, political machines, and systems that are responsible for generating it, is a connect the dots exercise that is wrought with political landmines. And it's a sophisticated individual who can begin a discussion that over time results in a movement of expanding accountability and responsibility for the outcomes that you teach them are the outcomes that we're engaged with in generating in this particular population in this time frame. That micro understanding of what you're doing, but get the political leadership to own that, so those outcomes they feel responsible for and scramble around trying to achieve or avoid. And then you don't criticize and become an enemy of them. That's your moment when you become an ally in the struggle to drop those outcomes. And I've seen it work well when there's a buildup over time of a relationship and trust that's based in an intellectual honesty that delivers the numbers that you truly are generating and owns them. So I'm very optimistic that this type of activity, which was not part of my earlier career at all, is now rising to the point where people are seeing they need this. because it's truly needed. You will not be successful in creating resiliency, sustainable programming that continues to evolve with the changing needs of the population you've assumed responsibility for, unless you have that dialogue. But it's a lot of orchestration, so I don't minimize how difficult it is, but it's noble, really, that you've engaged it. But I want to thank Professor Siwankambo for his orchestration of just this discussion. Is an unusual discussion. It's brought out things that I really wasn't anticipating would be brought out, but I can see now the importance of all of them, and I thank you for that.
Thank you very much for those comments. So, in 1 minute, what brought us here this afternoon is to discuss impact of the work we do. I'm sure Keith Martin is not here. I'll be asking him a question. We have these CUGH conferences every year. What is the impact of those conferences? I hope as you walk out of here, you'll start reflecting more and more deeply about the impact of your work, so that you are not satisfied with simply saying, we have had 200 publications. I'm sure we are together. And you are looking for something that is more meaningful to the populations that we serve. Thank you very much for coming to this session. And